Hello, my name is Thomas Duncan. I'm the Trauma Medical Director at Ventura County Medical Center. I'd like to thank you for viewing this important presentation on the massive transfusion protocol, its triggers, and shock index. I will start sharing my screen. The objectives of this presentation are to discuss the importance of why pre-hospital personnel are crucial in activation of our massive transfusion protocol, and to enable you to understand what the massive transfusion protocol is, the triggers, and how it improves management of our critical trauma patients. Hemorrhage is still the most common cause of death within an hour of trauma. Hence the term, the golden hour of trauma. Up to 50% of deaths occur before a patient arrives in the hospital, mostly due to exsanguination. More than 80% of deaths in the OR after injury secondary to exsanguination and coagulopathy. Now, about 50% of deaths after injury within the first 24 hours of that injury occur due to a similar cause, exsanguination and coagulopathy. And it behooves us to prevent these terrible triads that occur in our patients, meaning coagulopathy, acidosis, and hypothermia. The massive transfusion is defined as up to 10 units of blood administered to a patient within 24 hours. It's usually unplanned, and trauma is no accident. And it requires coordination between the blood bank, the operating room, the emergency department, and the ICU. And it's a highly complex situation that needs to be in play in order to have our patients receive the blood in a timely fashion. The massive transfusion protocol, also known as the MTP, is a method for delivery of ratio-based blood products. It's normally red blood cells to plasma to platelets. And the ratio is usually 6 of RBCs, 6 of plasma, and 1 of platelets, meaning 1 pooled apheresis of platelets. It normally comes in a cooler, which you see in the top right-hand corner of the screen. And you will notice these coolers in the emergency department when the MTP is triggered. It's also known as a 1-to-1-to-1 resuscitation, hence the term 1-to-1-to-1. It's a method of standardization for treatment of coagulopathy. It's also a method for treatment of acidosis, hypothermia, and hypocalcemia. And it's been associated with a decrease in mortality and overall usage of blood products for our trauma patients. These are the triggers that go along with activation of the massive transfusion protocol. When you call in to the MICN usually goes along these guidelines to determine whether or not we should activate our MTP. These guidelines are not for you to memorize, nor is the chart required for you to memorize, but we want you to provide the data for us to utilize to make the calculation of whether or not a patient requires an MTP to be triggered. For example, the shock index, which equals the heart rate divided by systolic blood pressure. If the shock index is greater than or equal to 0.9, that's positive, meaning if it's in the red on the chart on your right-hand side. In regards to that, if the shock index is positive and another MTP trigger is positive, either the patient has penetrating thoracoabdominal trauma or major amputation or major pelvic fracture, which may be difficult to determine, then we activate the MTP. But it's not for you to memorize. As far as the FAST scan goes, that's a focused abdominal sonography for trauma or an abdominal ultrasound, a chest ultrasound, which determines whether a patient has blood in their chest or their abdomen. That's normally done in the emergency department. Also, the INR or hemoglobin checks are not for you to provide because obviously we obtain those values when a patient comes in. But we want to implore you to continue providing the systolic blood pressure as well as the heart rate and any history that goes along with these triggers so we can activate the MTP. The utility of providing field MTP triggers are the MTP can be activated ahead of time before the patient arrives. And that way the blood is available when the patient gets to the emergency department, and we can start the process of administering the blood right away. The trauma team is better prepared in that respect, and then we have better outcomes. Also, morbidity and mortality decreases as a result of having the MTP triggered ahead of time before the patient arrives in the emergency department. It also improves the care for the trauma patient in Ventura County. Now, the data that has been provided in terms of using the shock index and pulse pressures for massive transfusion protocol comes from San Antonio, where Dr. Donald Jenkins is one of the big proponents of this process. He's also involved in whole blood, but that's a different topic. But the paper that was published in the Journal of Trauma and Acute Care Surgery indicates that high mortality in trauma patients that require the MTP occurs despite short transport times. Now, the need for early intervention of the MTP in the pre-hospital environment is really important, and shock index should be used as a trigger for pre-hospital MTP. Here are my references, including the paper I just summarized, another paper from San Antonio with Dr. Jenkins as the lead author for pre-hospital shock index and systolic blood pressure, also published in the Journal of Trauma and Acute Care, and the American College of Surgeons Trauma Quality Improvement Program, Massive Transfusion in Trauma Guidelines, which we go by. So I really want to thank you for being involved in this process. I want to thank the EMS. You do a great job and you keep our county safe. So once again, I'm glad to be a part of our county in terms of saving patients' lives, and we'll be glad to take questions offline. Goodbye.